my talk today is a bit of a mix between science and practice, and that's also kind of where I position myself. Although I'm an assistant professor for 4 days a week at the university, I also have a small private practice. I'm trained as a CBT therapist primarily, but I also worked in a setting where I worked in a psychodynamic center as the only CBT therapist, which was definitely an interesting experience in itself. But I did get some of that kind of perspective as a result. And I would say that my research is kind of independent of treatment orientations. But you will hear it in some of the things that I have that sort of background as a CBT therapist in the way that I talk about these things. And one of the things that I actually also mentioned in the book that we wrote, that I put the picture up on the slide, is that actually it's quite important for therapists to have their own narrative about Romana and feedback so that it fits their way of working. So I'm just acknowledging that my narrative mostly fits my way of working as a therapist, being primarily trained in CBT. But that it is a method that is independent of treatment orientation, and that you can fit it into the narrative of for example, client-centered therapy or psychodynamic therapy quite well as well. And we do have examples in the book as well, if you're interested. If you would be interested in reading about it, from therapists from those orientations. We've actually talked to other therapists from different orientations and asked them, like, how would they kind of integrate this way of working into the way that they work in their therapeutic orientations. All right, that being said, one of the challenges I think in working in this area of research is that we do not have like a single definition of like what is routine outcome monitoring. And to make it even more complex, there's also a range of different names for it. Some people call it measurement-based care, some people call it progress feedback. So what are we talking about when we're talking about outcome measurement or routine outcome monitoring? Now, this is one of my patients, and we've got a pre-treatment and a post-treatment score, and this is what we would call outcome measurement. So this isn't really outcome monitoring. So we just do pre and post measurement, which I think in most treatment settings is part of routine care, to have at least a try at like a pre and a post measurement to see whether treatment is effective. Now, what is different, what I would consider to be outcome monitoring, this is kind of a Dutch model, in which we tend to measure once every 3 months. So it's a bit more frequently than just pre-post. But for shorter treatments, obviously, there's not a lot of measurement. So here we see like a treatment that's a little over 6 months. It only has 4 measurements. So but this is kind of the typical model in Dutch settings, and this really changes around the world, like how often people measure. It does matter because any moment that you measure is a moment that you can intervene in the treatment, and you can identify that the treatment is, for example, not progressing well. So this is actually not the ideal model that I would prefer, and also not the model that I use in my own practice. But this is the model that is typically used in Dutch healthcare systems. That is low frequency measurement. But you can imagine that if you have relatively short treatments that are sort of within 3 months, then it's basically a pre-post measurement. So you miss out on the opportunity to actually intervene in treatment in this kind of sort of low frequency outcome monitoring type of model. This is the same patient that I showed you earlier, but now on the session by session measurement on the BDI. And well, if you go back to that first slide, you can see that this seems like a pretty straightforward, successful treatment. If we look at sort of the scores on a session by session basis, you can see that a lot more things happened during the treatment. There was a period that the client was definitely worsening. Then they got better, and then there was a period that the symptoms started to creep up again. And then finally, it ended with a successful end of treatment. But it was clearly not like as clean as that first picture suggested. And that is, of course, something that we know if we measure. So as a therapist, this way of measuring actually really contributed to the success that I had in this case, in my opinion. And oddly, mostly in this phase of the treatment. Do you see my mouse or not? No, then I will use the pointer. Okay. So mostly in this phase of the treatment, here, this is a big worsening of symptoms that you can probably observe as a clinician. What happened was patient was on antidepressants and ran out of her prescription for the Christmas holiday when she was visiting her family, went off antidepressants cold turkey, which is never a good idea. And when she got back, basically, she went from a mild to moderate to severe depression in the course of 2 weeks. At which point I also decided to see her more frequently because I felt like we were seeing each other every 2 to 3 weeks. So I changed the frequency to once a week. And then she got back on her antidepressants. And I think this part sort of the treatment is basically where the antidepressants started to kick back in. But as you can see here, she was not at session 8 doing better than she was at the start of treatment. And this is also something that's difficult to see if you don't measure, because it looks like she's coming from a sort of moderate to severe depression, goes back down in symptoms, and to then realize just on your clinical impression, whether that, that it's still not better than it was at the start, that is very difficult to know if you don't measure. Now, and then what I saw here was that sort of session by session, she wasn't improving. And so what I did in this phase of the treatment was really, really push myself each time to think, how can I do things differently with this client so that it does seem to click? This was a client who had therapy before. She already had a lot of skills. And she knew about it, but she didn't use them basically in real life. So she could recall them when we were in session, but she really didn't apply them when she was in the situation by herself. And so basically what I worked on really with her was like, how can we kind of get that to click so that she in the moment can realize how can she use these skills that she already has, and how can she kind of sort of work with that so that the stress doesn't sort of, the distress that she was experiencing doesn't go up throughout the week between the moments that we saw each other. And that finally we had like kind of a breakthrough moment, and this is what we would call a sudden gain. And then it really clicked for her, and she was able to then continue on her own. So basically, big differences are easily observable. Smaller differences or comparisons to multiple sessions before are more difficult to really observe with your clinical judgment if you don't measure. So that this just sort of from a clinical perspective, this is why I think routine outcome monitoring is quite useful for me as a therapist. But of course, as a researcher, my question is also, does it work? So now, this is basically a model where we measured. In this case, I also discussed it with the feedback, but the thing is you could potentially just do outcome monitoring, which is, for example, what we see in NHS talking therapy. There's a big focus on the measurement, not so much on the discussion. And so the feedback part is where I would argue is what is needed to really for the outcome monitoring to have a real effect. Because if you just measure but don't discuss it with the patient, then it doesn't do some of the things that it can potentially do sort of to the benefit of the treatment. Okay, so now I have a question for you as the audience, and I have 3 questions in total, so keep your Mentimeter open. If you should be able to scan it, or otherwise go to menti.com and use the code. And then I'm gonna like escape from this. Let's see. this so that I can also see what you are doing. I probably need to push present before I can get responses. Oh, this is too far. Okay. So I see the first responses are coming in. Okay, so we've got 20 people now. So what you can sort of see emerge here is that a fair amount of people measure but don't discuss. There's a group that does low frequency feedback, and there's a group that really uses it as sort of continuous measurement and discussion. But you can see that that's definitely not the majority at this point, which no, at least, well, I hope that that number will change after this talk, but we will see. Okay, let's go back to the presentation. All right. Now, a brief sort of reiteration of why we need feedback and why we need to use monitoring as part of our treatment. What we see in scientific research is that 2/3 of patients improve in scientific studies. But when we look at clinical practice, then the results are really less optimistic. And we see that 35 to 50% of people only benefit. And then particularly, I think people from underserved communities, for example, they struggle a lot more in getting treatment success. And so that's also one of the topics that I'm going to be talking about today to some extent, that having certain risk factors, it could be demographic or otherwise, is something that you can actually work with actively when you are troubleshooting when a client's not making progress. Now, one of the reasons is potentially therapist self-serving bias. We see that about 2/3 of therapists consider themselves to be on the top 25% in their profession, which is, of course, statistically impossible. But it's also not something that's really unique to therapists. You basically, in general, people have a self-serving bias. We all think of ourselves as more attractive, more intelligent, etc., then we objectively are. So if you were to ask a barrister, they would also overestimate the amount of cases that they would win, for example, compared to if you put their actual numbers next to it. Now routine outcome monitoring and feedback was considered sort of, 20 years ago, really by big names in our field, like Bruce Wempold or Len Bigman, Michael Lambert, Ken Howard were names of people who were really saying, like, this is a promising method to really enhance treatment outcomes in routine care. So many of the interventions that we have in terms of trying to improve treatment outcomes really are about creating new interventions. So we come up with a ton of new treatments. I think there's over 1,000 different treatment methods that we have by now. But what we also see is that the results of treatment outcomes have not improved substantially in the last 50 years. So that's a bit of a problem in terms of, like, how do we obtain better outcomes? And one of the things that is nice about, I think, routine outcome monitoring and feedback is that it's not a new method. You do it with basically the methods that you already use, but you basically get a way of alerting yourself when things are not going well. So back to our case. So in this case, I only had the score. So there was no bells and whistles. This is what we call raw score feedback. So there's no information other than the direct score of the patient on the questionnaire. But there are models these days that are a little bit better. And that's, for example, when we're monitoring with prediction. So this is from a study that we did in the UK. within the then called IAP, now NHS Talking Therapies. And we use the PHQ-9 and the G87 as instruments to measure patients' progress. And what you can see here is that there is a predicted outcome for the patient, and that's compared to the actual progress that the patient makes. So if you look at kind of the red line and the green line, so there's a red line here, there's a green line here. The prediction of the patient is actually in between. You don't see it, but there should be like a bit of like a black dotted line in the middle. We're not showing it because it's just getting really confusing. Lots of lines for clinicians to watch at, to look for. But the red line is basically what we call the failure boundary. So if people cross that red line, we consider them to be not on track or a signal case, which means that they deviate too much from the expectation that we consider is worth paying attention to. And then the green line is basically that you're doing significantly better than expected. So if you cross the green line, sort of more than one session after the other, you could even think about maybe ending treatment. And one of the things that routine outcome monitoring can do, especially in settings that were quite protocolized, is that it can enhance the efficiency of treatment. And that usually happens in the on-track cases that go well, where you can basically round up treatment sooner for those patients that do well. All right. Now, that fluctuation that we saw earlier, the signal, why does it matter? Because it could just be, you know, some amount of fluctuation. Is it even linked to treatment outcomes? And that was a very important question. And this paper that I'm citing here from Lutz and colleagues assessed that. And what we see is that the chances of having negative treatment outcomes it's about 30% if you don't have a signal. So if you are an on-track case for the entire treatment, your chances of not benefiting from treatment are about 30%. If you have one signal, that chance goes up already to 53%. And if you have two signals or more, chances are more than 70% that you will not benefit from treatment. So there is a very clear connection between getting that signal and benefiting from treatment. And that's, of course, very important because it means that we need to pay attention to that signal because it severely increases your chances of not benefiting from treatment. Now, this is an example, for example, of a collaboration that we did with PCMIS, who have like electronic patient files in the UK. And here we see that one of the clinical leads from IAPT at the time for the study that we did said, since we started using outcome feedback technology, we've really seen an increase in our recovery rates. And that's kind of more of kind of practice-based example of how outcomes can, like using this kind of methodology and technology of having data-informed treatment, so to say, can really enhance your outcomes. Now, the more advanced systems also have something called clinical support tools, and clinical support tools measure treatment processes. So when a patient is not on track, an additional questionnaire is used, and in that questionnaire, we assess the therapeutic alliance, motivation, social support, and coping with negative life events. And so what we see in the literature is when feedback and clinical support tools are combined, it really improves treatment outcomes. I'll show you in a bit how much. We also see that patients who are not on track typically score higher on these domains than patients who are on track. So they have more problems on these domains. And we also see that there is a clustering. So, for example, there's a tendency for therapeutic alliance and motivation to cluster together. And that makes sense to me in the sense that if you have low motivation, it's also hard to form like an alliance with your therapist. But also, if the alliance is not good, it's hard to stay motivated as well, potentially. And we also see something similar with social support and active life events. So what you see is that if people have low social support, don't feel they have people they can talk to. They're really dependent on, oh, this always happens. I'll go back. Okay, let me rephrase that. I was a bit thrown off by my automatic moving of the slides. That if they have low social support, the therapist is pretty much the only person they maybe feel like they can confide in. And if something negative happens, then the distress, so until they see the therapist, really goes up until they have a moment to share. And so that makes it a very vulnerable state to be in, because if you're really only reliant on your therapist, that can be very difficult. For example, in one of my own patients, she had a fairly large social network, but was not really sharing personal information with her friends. And so one of the things that we worked on with was for her to share a bit more about the things that were happening to her. And she had actually quite a lot of negative life events that had happened to her. And when she started to share with her friends, she noticed that they were very receptive to it, that they got more of a bond, and the friends also started to share things about themselves with her. And so that really promoted that feeling of like, there are people, you know, if I have a tough time, there are people I can talk to outside of the therapy sessions. And so even when people have a social network, it doesn't always mean that they feel that they can share with their network. So that's also something to consider. All right, now the scientific part is coming, and that is, does routine outcome monitoring improve outcomes? So if we look at the effect sizes, they're not very big, but they are robust and they do have a positive effect. What we see is that overall in all patients, there's a slight, sort of a small effect of D is 0.15. And when we specifically look in non-on-track cases, we see that it's slightly higher, but not much. It's 0.17. Now, this is partially due to the fact that different feedback systems seem to have different mechanisms. So specific feedback systems that really focus on identifying not on track patients and sort of providing feedback to that, on sort of, for example, clinical support tools, etc., we see that those systems are more effective in on-track patients, whereas other systems that are focusing more on like also feedback on alliance, for example, they tend to be more effective for on-track patients and at increasing efficiency. And so there are really some differences in sort of what is the focus of the kind of the feedback system that you use and how does it then influence your treatment outcomes. So there are some differences there, and that mostly can be seen in the difference between the two major systems. So you've got the OQ system, which is mostly good at identifying non-on-track patients and then improving their outcomes, whereas the ORS, SRS, or PCOMS system, also sometimes called FIT outcomes, is a system that is more efficient in the on-track cases and also in reducing dropout, for example. So it's more of a kind of a communal, like a shared decision-making type of model where also the feedback is directly discussed in the session. And the feedback on the alliance is also discussed within the session. So it's a bit of a different model, and it seems to have also a slightly different working mechanism as a result. Now, I casually said dropout is reduced, but it's actually very important because we know that dropout is one of the big problems we have in mental health care. Between 25 and 40% of patients drop out of therapy before they are improved or like agree with the therapist that they should end treatment. And so by reducing dropout, we keep some patients who are quite vulnerable and not functioning so well in treatment. And we also know that dropout predicts future dropout. So if people drop out, the chances of them dropping out again are higher. So we really, if we can prevent it, I think we can really keep in some patients that are vulnerable and give them a chance to benefit from treatment. as I said, I would quantify sort of the amount of what the CSTs add. So we see if we have the plain feedback, the one that I showed about my patient, in not on track patients, that is not so effective. One of the reasons could be that as a therapist, you can just say, oh, you know, there's some fluctuations. That's okay. That's normal. There's a lot of myths in psychotherapy about what needs to happen to patients. So a lot of therapists would say things along the lines of like, oh, but a patient needs to worsen before they get better. I think that's a myth that almost everyone knows. Well, that's not really what the research data shows. We actually see that people who have early change in a positive direction have much better chances of benefiting from treatment than people who worsen. And then there's another myth that says people get insight into their problems, so their scores go up because they are more aware of their symptoms. And that also doesn't really seem consistent with the research out there. I mean, it can happen to some degree, but not to the degree that you really would see a worsening of symptoms in most patients. Now, of course, there are some patients for whom this is true, which I think keeps the myth alive. But if we look at the research data, that's typically not the case. So when we don't give any signals to the therapist and just use the graph with the raw feedback, you don't really get an effect in not on track patients. In on track patients, it's a bit different. You could still have a benefit in being more efficient and better collaborating with your patient, but in not on track patients, it does not really do much. Now, if we then add the expected recovery curves and we give a signal, then the effect size does go up and it becomes around a small effect size. But then if we add the CSTs, you can see that then particularly the effect size goes up. Now, what is interesting to say, I didn't put it in the presentation for today, but one of the things that we see is that if we have a group that has a lot of risk factors on different, like, for example, having access to problems as well, but also things like being divorced, being unemployed, being in a minority, and things like that. So there's a couple of known risk factors that we know sort of from other research that increases the chances of not benefiting from treatment. You can see that if we have that sort of high risk group, we see that I refer to them as high complexity because they have a couple of risk factors that if they then have multiple risk factors, they get a higher complexity score. And then we see in those highly complex patients that especially the CST feedback is highly effective. We see very, very big results with this combination. And my hypothesis would be that it is because in those patients, therapists struggle. They don't know what to do. They're highly complex patients. They're not progressing. And then the CST likely helps you generate ideas about what's happening in the treatment, what could be a starting point for intervention. And so it seems like particularly in that group, that also includes underprivileged groups, for example, it really works to work with these additional measures. Now, if you don't have these measures, you can, of course, always assess the domains. And I will get to that later. Whether you do that formally with a questionnaire or you do that in a conversation with the patient, you can always, of course, ask about these domains the moment a patient gets not on track, even if you don't have the clinical support tool. All right. Then if we look at the dropout, there we see that the PCOM system or the ORS-SRS, which also has feedback on the alliance, is the system that is more effective. So here you can see that the odds ratio of not having a dropout goes up. It seems a bit contrary that it's a higher value, but it's the way it's scored. And then the OQ system also, to some extent, reduces your chances of dropout. But not to the extent that this system does. So you can see that when there is like feedback on the alliance, and this is continuous feedback on the alliance, not just like once when people are not on track, that it really also influences their dropout rate. So as you can see, there's benefits to different feedback systems, and they have slightly different working mechanisms. So it also depends a bit on the group that you're working with, what system fits your facility the best. And of course, you don't always have the opportunity to choose, because sometimes your organization has already picked a system for you, and that's the system you have to work with. But I think the principles of feedback can be applied with any measurement system, as long as the system at least measures the things that you expect to change in your treatment. So, you know, in for example, severe mentally ill patients, you wouldn't necessarily expect the symptoms to really change that much, but you would maybe look at quality of life more. And so it does matter that the feedback measure fits the population that you're working with. But in principle, the idea of measuring progress on any outcome measure and process on any process measure, and then that forms the base for discussion with the patient and kind of like how you shape your cases. That is a very basic principle that can be done with pretty much each system. Okay. Now, finally, it's worth noting that it's also cost effective, which I think is really important for the policymakers if they are indeed present today. What we did here in the UK, we did a pilot study with the outcome feedback with the PHQ-9 and GED7, as I said. And we see in the control cases that the cost of treatment per client were higher than the cost of treatment for the outcome feedback cases, and per patient we saved £100, and so in total over 249 patients we saved £24,000, and we got a £20,000 grant for this project, so we basically earned ourselves back. So all right, now let's focus on how to use Roman feedback in practice. As I suspect that the majority of people here are clinicians, but even if you're a policymaker, I think it's useful to learn a bit more about how to do it. So let's see, let's start at introducing routine outcome monitoring to patients. So one of the things that we see sometimes is that without a proper introduction, patients will kind of argue that they don't want to do it, or sometimes clinicians think they don't want to do it, or they feel bad about asking patients to complete measures, for example, each session, and they feel like it's burdening the patient. It's not really true. What we see in the research literature is that actually patients, when it is actually integrated into treatment, they really value routine outcome monitoring and feedback. For example, in a German study, they gave the feedback a score of on average above 8. On a 10-point scale, so they really enjoyed having the feedback. Now, the thing is, if you don't use it, then they will quickly stop doing it. But you have to let them know that you look at it for sure. Now, to start with introducing ROM to patients, one of the things you start with, obviously, is explain the purpose. Then you want to make it personal, why it matters to the patient. So it's not just sort of like, this is how we work, but why is it relevant to you as a patient? And mostly one of the things that you could say potentially is, for example, you could say something along the lines of, you know, in this way, we can really keep track of how you are doing and how your progress is going in treatment, and if things are not going well, we're, you know, quick to spot that and things like that. So really make it relevant, that it's a way to basically measure their personal progress, and also really kind of create a sense of ownership in the patient to then, you know, kind of, this is your data. One of the things that can really help is use familiar concepts like metaphors and scaffolding, for example. So you could potentially like use things like a thermometer or blood pressure as a potential metaphor. How you, for example, say that you have blood pressure problems and you go to your GP, and they measure your blood pressure, it's too high, the doctor gives you some medication. Next time you come back, the doctor asks you for like, okay, how are you feeling? Well, I still don't feel quite well. Okay, let's increase your medication without measuring your blood pressure. Would you feel comfortable? Well, no, most people don't. So then it's kind of a metaphor to use, like, okay, so it's, this is a way for us to keep track of, like, should we go on the way that we're doing, or should we make any adaptations? What's quite important, and I think especially with, for example, low SCS groups, is to also really check if people understand. So one way to do that, for example, is to not just say, is this clear to you, but really sort of like ask people, could you briefly summarize what I just said? And then they can easily check, and you can easily check if they actually understood what you were saying and paid attention. The other thing is to set expectations. So people might feel like, oh, I have to fill out a lot of questionnaires if you don't tell them that's part of sort of the way that it works. So you also and also want to maybe talk about how often you're going to discuss the feedback. Is this something that we do every session, or is this something that we do whenever things are not going well, and so many times at least, it's at least after 5 sessions we discuss it, or sooner if it doesn't seem to be going in the right direction, for example. By the way, even if you, it's very easy to actually, if things are going well, to really just mention to the patient that you saw the graph, basically. It doesn't require a lot of time. I know some therapists really worry about that it's taking up a lot of time in treatment. So personally, I just typically say, things like, oh, I saw in your questionnaire that things seem to be a little bit better this week compared to last week, but you do seem to still be struggling with sleep problems. Is that something you want to discuss today, or should we continue with what we were working on before? And that's basically, that was like a 30-second sentence, and I've acknowledged that I've seen the patient's response, that I've seen that there are some issues still and something that they struggled with that we're currently not working on, and I've asked them if that's how they want to keep that, or if they want to make some changes, and basically inviting their inputs. So it doesn't have to take that long. Explain also how you interpret the data. So sometimes there's like cutoffs or like norms that you compare it to. Some feedback systems use like normative groups, for example, and you then kind of want to make sure that the patient also understands what the graphs are saying and what they mean, and things like that. Also, some ROM systems have questionnaires with multiple scales, so it's also good to then go over the different scales and what they mean. Okay, now one of the things is also to consider is your recovery target feasible? This is something that we really encountered when we were doing the study in the NHS talking therapies, where I think most organizations have a target of 50% improvement for their service. And so one of the things that therapists told us is that having these expected recovery curves was also an indication of whether with this particular patient, it was actually feasible to achieve that recovery. So for some patients who were very complex, for example, the expected recovery curve was like not even reaching that black line, which is the threshold for the PHQ-9 to be classified as non-clinical. So for some people, they might not even be expected to reach that. And it helps therapists a lot to know that in terms of like, is this a patient that I can even get to that target with or not? And in that case, if it's not a patient that is a feasible outcome in the system that you work in, maybe one of the outcomes could be that you refer out sooner to more specialized care, for example. So that's also a way to look at it. Then the next question is, what are the potential risk factors in this patient? And so particularly these models in this particular case are really based also on risk factors. And this is work done by Jamie Del Cadillo, who has been doing a lot of work in the UK on this topic. And so he really looks into, you know, what are risk factors? And I'm going to show you an example of that quite soon. And then the third question you can ask yourself is, okay, if there are these risk factors, are they modifiable? Can I work with them or can I work around them? So for some of these things, some of these risk factors, you can't change, for example, somebody's ethnicity, but you can see how you can adapt your treatment, for example, to be culturally competent for this particular patient. So those are things that you can ask yourself already from the get-go of the treatment and start. So here is the Leeds Risk Index developed by Jamie. And you can see here that in this version, they have like risk factors for like a young patient. So that has to do with age of onset. If it's younger, people tend to be at a larger risk. Then is the patient unemployed or on benefits is another risk factor. Do they have a self-reported disability? Were they having very low expectancies of treatment outcomes? So that could be an indication that they're very demoralized or they have low motivation, for example. So that also increases the risk if they have low expectancy level. And then the level of impairment is also a factor. So here they have the WSAS measure that looks into functioning. And so if people are having poor functioning, then that increases the risk factor. And then in this case, how depressed is the patient on the PHQ-9? And so that then results in a risk score of between 0 and 21. And the higher the risk, the higher the odds that people are not benefiting from treatments. And so the expected recovery curves for those people also look flatter. They tend to not show that this patient is likely to improve. And so then in those cases that are high risk, you can already from the start think about, is this a feasible approach with this patient? Should we think about referring out? Should we think about adding medication already and things like that? So that these patients are not kept in a low intensity treatment, for example, for a period of time where they actually might get quite demoralized and leave treatment and drop out and things like that. Okay, now when you have a treatment that is progressing well, which is typically about somewhere between 50 and 70% of the cases we see that treatment progresses well. What you need to be able to do as a therapist is recognize patterns of change, determining what is meaningful change for the patient, and discuss the feedback and also think about whether you can consider ending treatment. And so there are a bunch of patterns that are worth discussing briefly. So one of the big ones is a sudden gain, and the sudden gain is something that came out in research by Tang and DeRubis, and they found that when there is a sudden drop in symptoms that is significant, and that is sort of a big drop, at least 25% of the score compared to this score, and that is before it's stable and after it's stable, if that's what we call a sudden gain. And when people have a sudden gain, their chances of benefiting from treatment improve. So having a sudden gain, when I worked in Dr. Rubis's depression clinic, we would always, I did my postdoc there, and when we would always, amongst the postdocs and PhD students who were treating patients in the clinic, we would always like notify each other if we had a sudden gain. We did like a little happy dance when we had, because we knew that the odds were quite improved now that our patients would benefit from the treatment that we were giving. I don't think that happens in other places, but we were at the source, obviously. This is an example of a turning point. So this is typically something that is not happening with a lot of patients, but it is possible that there is indeed first an increase, and then there's kind of an insight moment in the session where then people are then dropping in symptom levels and are improving. And And so there are, of course, other patterns. We don't have the time to go to all the different patterns that are there, but I just wanted to give a few examples. Then when we discuss the feedback, you can actually talk about it in sort of by tipping on, like touching upon certain things. So one of the things that's important is, does the patient recognize themselves in the score? So we know that sometimes there can be a bit of a disconnect of like seeing a score and basically how are you feeling? And so it's important to really ask if they recognize themselves in the score and if they agree with the score. And then the other thing is that how do they feel about the amount of change? And you will see that actually in the video that I will show later, is that we tend to have a different idea of how much change people are expected to make than patients themselves. So they might think, oh, after 4 sessions, I should be feeling a lot better. And if they don't, because they're more complex and they may need a longer trajectory, for example, that is not always something that we discuss. We don't always say, we expect you to need this many sessions. And so having that expectation discussed is quite an important thing to know, that it can be also very disappointing to the patient that they're not yet making enough progress, for example. And then the other question that you want to address is, does something need to change? Now, when treatment is not progressing, what you can see is that you want to kind of recognize patterns of no change. Then you want to be able to do clinical troubleshooting with the patient, as well as discuss feedback and supervision, if that's something that you have. Not all healthcare systems in the world have standardized supervision like it is sort of embedded in the UK. In the Netherlands, after the phase that you are trained, you no longer have supervision. You do have like multidisciplinary team discussions, for example, about your cases, but you don't really have supervision anymore unless you look for it yourself, but it's not a requirement. And that is also true in many other healthcare systems. So being able to discuss the feedback in supervision is not always possible, but often you are able to discuss it with colleagues in like team meetings, etc. Now, this is, for example, a negative trend. It goes quite slowly, but the symptoms of the patient definitely are creeping up in this example. And here we see the opposite of a sudden gain, which is a sudden loss, and that is associated with poorer outcomes as well. So here we see, if you do have a sudden loss, that's really something to be mindful of if you see that kind of pattern. This is an example of high variability. So we see that the patient goes up and down, but overall the trend is not that they're improving. So that's also something to then address. And so now I'm getting to the point where we have, I want to discuss the clinical troubleshooting methods, whereas what we see is that there's a bunch of steps that we recommend when a patient is not on track. And the first step is to assess clinically relevant factors. And then once you have identified these, you want to kind of formulate how it impacts the treatment progress. Are these factors amenable to change? If they are, then you can modify your treatment, for example. If they are not, see if you can work with or work around them. And then you again evaluate if the changes that you made or the workarounds that you created had an effect. And you can review the treatment program ultimately. Should we resume with the evidence-based treatment? Do we continue with an adaptive treatment, or do we consider alternative treatment? And so I wanted to then show you kind of the first step in more detail, because I think it's something you can already do without necessarily having a lot of training and a lot of things in place. And that is basically assessing the relevant factors. So if we look at the factors, we see that there are patient factors, there are therapist factors, therapy process factors, and wider context factors. So I don't know about you, but what I've seen a lot happening is that when a patient is not on track, our first tendency is to say it's the patient. Because that's the easiest for us. Because it doesn't hurt our ego or a self of competency. And so we tend to speak, like I catch myself doing it sometimes. This is a really complex patient. It's hard to get, or they're not motivated, or they're, you know, kind of difficult to work with, or they're really complex. All of this is, of course, potentially true and is worth looking into in terms of, you know, kind of like what could be the case that is in sort of impeding treatment. But we should not stop there. So the question that we don't really like to ask ourselves is, what am I doing? So am I potentially overconfident with this patient? Do I feel burnt out? Am I seeing so many patients that I see that this patient's always at 4 p.m. and I'm just out of energy and I'm just not managing to really do something useful with a patient with this level of complexity? Do I have a low job satisfaction? Do I have good facilitating for interpersonal skills, or do I need something to develop more of that? Do I reflect on my cases enough? You know, critical reflection. Am I training myself in the skills that I need? Do I do, for example, engage in deliberate practice, which is a particular method of sort of improving yourself as a therapist? If we look at the therapy processes, we see that we can look at things like alliance ruptures, lack of consensus about goals, differences in expectancy, like I just discussed about sort of how much progress do you make in treatment, motivational deficits, and, you know, all of these things that could potentially get in the way of making progress in treatment. And these are more, of course, of sort of an interaction between the patient and the therapist. And then if we look at wider context, we see things like life problems and events that exacerbate the psychopathology. You can think also about socioeconomic deprivation or things like debts. So say that a patient is in debt, they have very low funding, income, they're struggling to make ends meet. Then even getting a bus ticket to come to therapy could be a major issue, and they might, you know, sometimes not show up, and they might, you know, things like that. And they may have a lack of social support, as we already discussed as well. So there are other things in the wider context that are relevant to also take into account. Now, I am now going to show you a brief fragment of discussing feedback with patients. And I can't, this is originally a longer fragment of like 15 minutes in which we go over all of these different factors. But I'm now showing you particularly the part where I ask about the therapeutic factors and if there are things that I, as a therapist, should do differently. This is, by the way, an actor who is also a therapist, so it's not a real patient, just so you know.
Daily life. Yeah. Obviously, we're working together to see if we can get your depressed symptoms reduced. And so I was wondering, is there anything in the therapy that you think would need to change that could potentially have contributed to you feeling not so well right now?
Wow, that's a hard question. No, I don't think it has contributed. But I'm sorry to say that I hoped for a more rapid improvement. That's so slow, and now this relapse, this deterioration, more symptoms, less positive mood. So when does therapy kicks in?
Right. Sure that if there's things that, for example, now that you're not feeling well, how do you feel it has affected your motivation, for example?
Sorry, it's a bit jumpy because I cut like big pieces out of it. So just so you know, I also see now that we're quite close to finishing time, I think. So I'm going to wrap this up. Okay, let's see where we're at. So basically, based on this, I'm at almost the last sheet, so that's good. Basically, based on this sort of assessment of relevant factors, you can think about how do these factors like make it difficult to cope with daily stressors, interfere with patient goals, and interfere with mechanisms of change in treatment. So for example, in CBT, it can really stimulate avoidance, for example, and how do they interact with each other. And then that is the end of my talk. Basically, the kind of a summary of things that you could immediately change based on this talk, because I want to make it kind of like useful for you, is things that you can immediately do is things like assess at the start of treatment if recovery is feasible, what are risk factors for these patients, is the treatment progressing well, make sure that you assess regularly, even if you can't do it session by session, things like patient and therapist factor, treatment processes in larger context. If you have the opportunity, discuss the supervision, and then adapt your case formulation and treatments if needed. And that's the end. If you want, you can leave some comments still here about if there are things you want to change and what you feel. There's some resources. I think the slides might be shared as well or not. This is free resources on YouTube that you can see videos. And this is a series I did for Cyflix for those of you who have a subscription to that. And that's it.
Fantastic. Thank you so much.